We shall now go on to our next speaker, Dr. NAVEEN Gopal, who's a senior cataract and refractive surgeon from GOPAL Netralaya, and he's going to share his very interesting teaching pearl. On to you, Dr. NAVEEN.
Thank you, madam. Thank you. 1 second. Yeah, but now, am I sharing
Yes.
the screen?
Yeah.
Am I sharing the screen, madam?
No, you're not.
1 second, madam. Is it visible now?
Yes.
Okay, thank you. Yes, thank you so much, madam. Thank you for this wonderful opportunity to present my interesting case, what I've done in my life. Without any delay, I would like to present a grossly subluxated cataract. This was a HIV positive patient coming in with he was a 50-year-old with a grade 2, grade 3, as you can see, with a 270 degrees zonal dialysis. Without delay, I'll play the video. As my previous presenters have presented, doing the rexus is the most challenging part. One tip what I would like to give is I tamponade the cataract both from front and from behind with the OVD, with the high molecular weight OVD, so that the cataract is sandwiched and you get a good hold of the cataract while doing the rexus. Next, I've put a capsular bag hook to catch hold of the bag so that it doesn't drop in when I'm doing the phaco. Very gentle phaco, grade 2 to grade 3, easy phaco. But the only challenging part is the whole bag comes into the tip when we are doing the phaco. So the parameters should be very low. Usually I operate at 550, 600 vacuum. Here I'm hardly operating at 200 vacuum. As you can see, the whole bag, almost the whole bag is in the AC. There is about 360 degrees of zonal dialysis. Now the easy part is take out the bag and put in the iris fixated lens or a scleral fixated lens, as discussed previously. But I wanted to save the bag and I wanted to challenge myself. Very few times we get this cases for us to operate. So what I decided to do was put in CTS or CT segment or Ahmed segment. One CTS is not enough because there is 360 degrees of dialysis. There's no support at all to the back. So I make a tunnel, go from the bed, railroad the proline sutures, tie one of the CTS, and put in the bag. Now once 180 degrees of the bag is stabilized, the same procedure is repeated on the other side. Nowadays, of course, I prefer to do a Hoffman pouches rather than the scleral tunnel. This was around 6 or 7 years back. I was not very well versed with doing Hoffman pouches. I was comfortable doing the scleral tunnel for fixing onto the sclera. Same procedure is repeated onto the other end. And now there is 360 degrees of support for the bag. Now, after spending about 1 to 1.5 hours of my time, this is the happiest moment, putting the single piece onto the bag. The bag is quite stable, and I have been following this patient from past, say, 6 years now. He's doing well. Vision is about 6.9 parts unaided, and aided is about 6/6. If you give me 1 more minute, I would like to present one more case for just a minute. This I had managed around 10 years back. I did not have access to the capsule bag hooks or Ahmed segments. Here I had used double Sioni ring. Double Sioni ring is very challenging to use. CTS is a cakewalk compared to this, because before putting the double Sioni ring, we have to suture in both the ends and put in the bag. And once the Sioni ring is in the bag, what happens is the sutures tends to get entangled, and to unentangle the sutures takes a lot and lots of time. So anyhow, this procedure I took around 2 hours. Same principle though. only difference is the suture entanglement. This was a traumatic cataract again, and I was able to fix the bag onto the sclera and put the single piece onto the bag. And here I was not very sure of the wound, so I had to suture the wounds. And no, there's no need of putting the suture to the sclera because the sutures are embedded into the tunnel. And I'm very gently removing the visco and making sure there is no vitreous. Thank you, madam. How do I?
That was a very challenging video which you showed, and thanks a lot, Dr. Naveen. Dr. Gaurav, I would want to ask you, would you stop sharing your screen?
Yeah, I'm trying to, madam.
Yeah, Dr. Gaurav, after all these kind of dramatic surgeries, you will have to stop sharing your screen.
I'm trying to do that. How to do that?
There's a
admin can help.
Admin can help.
Stop share. Yes, done.
Yes, about the IOL bag dislocation, which happens, the subluxation of the IOL bag complex. How would you feel is the best way to manage them after all the elaborate surgeries done?
Yeah, so I think nowadays we are handling a lot of such cases of subluxated cataract. So what might be a good idea is to ensure that, if we are fixating them, it's good to fixate at 2 points if possible. If not, then at least have a CTR in place and maybe a 3-piece lens. If you have a 3-piece lens and a CTR in the bag, in future, you have options to fixate these lenses because you can pass a suture around the 3-piece haptic or around the CTR, just in case, they have further subluxation or the zonules give way in future, you will still have recourse. If you've put in a single piece lens, it becomes much more challenging in these eyes to kind of in the future plan for something in the future. Right now, I think it's important that if it's a degenerative process where the zonules are likely to have progressive weakness, then it's better to do a 2-point fixation at both sides rather than just at the point where you are, having a problem right now.
Yes, very valid. So anything else, Anagha, you want to ask before we move on to our next 2 speakers?
Ma'am, excellent surgeries and very well done.
Very well done.
Very well done.